So next I'd like to bring up our last speaker. It's Dr. Urs Schneider. He joins us from Germany. He's head of the Life Science Unit, head of Biomechanics Research Department of Fraunhofer Institute, IPA Stuttgart, Reader University Stuttgart, and Tübingen. Close enough? All right, here we go.
So, thank you very much for inviting me. Merci pour m'inviter. And I'd like to speak some aspects about innovation. So that was a wonderful morning view. For me, it was the first time here in Banff, and it was just a wonderful morning. I think 7 o'clock this morning. So I'll have a little lecture now, and afterwards we'll have the panel discussion with Yvonne, Sylvia, and Gord on this topic. I'd like to lead you through what is Fraunhofer, why innovate, why is that a topic, definition of innovation. Just a second, I'd like to get my laptop somehow over. I think that's perfect, okay. Good. Some aspects of innovation happening in other fields. Industry 4.0 was just mentioned, and some aspects of innovation O&P that I see. I work for Fraunhofer Institute. It's the largest technology research institute of Europe. We're 24,000 people, and I work in the Stuttgart lab, and I'm head of a biomechatronics team of 25 engineers and 20 students. We are a private non-profit organization. It's a research institute with a business model. The institution has to show every one of us that 1/3 of research we do per year is financed by industry. So industry has to love us. So we're always pushed to be close to industrial interests there. MP3 is maybe a result of Fraunhofer, you know and use. That's our Stuttgart branch. What I'm doing in our lab, this is very much about analyzing human motion for technical solution, trying to develop digital processes for quantifiable planning of devices. We develop exoskeletons. There's Stuttgart ExoJacket will be a product in about 1.5 years, and we work in all kinds of powered rehabilitation things, especially with US colleagues. Just a picture, this is Stuttgart, the town where I'm from. I'm a Stuttgart boy and I work there, the capital of our southwestern state. That's the local landscape just south of Stuttgart, the little river Danube, growing to a large river in Europe. Now to the topics. Why innovate? 2 challenges. The one is a socio-economic challenge. I think the future is very much about affordable healthcare. We have growing healthcare costs in aging societies with a dominance on chronic musculoskeletal illnesses, which is good for the future of O&P, but there is a changing ratio of healthcare payers to treatment receivers all over the planet with all these old people out there. And there is a societal interest in continuous medical research for improvement of treatment and quality of life. This again will bring up new devices, new treatment ways, which may be more costly, but we don't want the planet to stop medical research. So on top of healthcare pressure, with new technologies, new cost questions come in addition. So this is also all poured out over poor O&P, and we have more and more question on how can we prove the change of quality of life with our device. Can we show evidence to the cost decision of a treatment? And why did you spend these many hours on the patient? And what did you do in these days? This is things that's happening, I think, not just in Germany, and it is happening. And beside that, technology challenges occur. We have some fast changes in consumer electronics, consumer products, and technology for general industry, which is in daily life hard to understand, hard to assess. Can I use that? Can I use 3D printers? Are they costly? It is difficult to put that into daily decision making. How to evaluate quality, cost, benefits. At the same time, these things happen, and they will influence medical diagnostics, treatment, products, processes, and services. And therefore, I think you have this good and optimistic picture here for the Congress. This is why I took it in. Definitions of innovation, what is it? Wikipedia says, our new Bible, I think, innovation is defined simply as a new idea, device, or method, whereas here locally, the Innovation Department of University of Calgary says innovation is a process through which knowledge and new ideas are applied to create new economic and social benefits, as a general definition. Industry 4.0, mass customization or mass personalization. This is something we are used to in prosthetics, orthotics. Treatment is always individual decision making to an individual. But all industry has to do that in the meantime. This graph is just to show once for general industry a graph of product diversity versus product volume per variety. This is where the craftsman in the 19th century started, and where production efficiency went like to Ford Model T, saying Model T can be bought in any color as long as it's black. That was like the hype of not customization. And then already with the Beetle started people who wanted their cars with different colors, even different window shapes and things. And today, no BMW is bought anymore with super individualized things that unfortunately every client wants. It's a nightmare for the manufacturers. But what happens, a lot of technology changes have to happen. There's real pressure on the car industry. And now we have to be aware, is there maybe the one or other scanning technique that became cheap because of that? Is there maybe a fast new printer that was produced by them? And maybe is there something we may learn also from closer to O&P than the car, implant manufacturing? In the past, you would have thought implants are way more expensive than O&P components. I can tell you a hip implant is paid in Germany for by the German state and insurance for something like $1,000. So a hip implant is way cheaper than like any prosthetic component today. So we may learn from their customization as well, and we have to be aware that things are going on. Then there is another field of fully mass production. This is Nike and Adidas. And one in their management said last year, the client is to buy what we thought he would like the year before, because it was one design produced by millions the next year, and then everyone had to hope. But in the future, the client will decide himself what he wants, and this will be produced for him locally. So the client enters a shop of Adidas, will be measured with sensory and scanners. Then he will decide on the base model, on the shape, the color, and all that. And the production will be within hours. So then you think, how crazy can Adidas or Nike be? When will they do that? And I have to tell you, this shop will open in November. So in November, mass producer Adidas sells your individual shoes, and they produce them in the shop. So therefore, this has a certain analogy to O&P. It shouldn't make you fearful of changes, but see the chances with maybe the one or other scanner or other device that may have become cheap with them as well. Now this is the threatening slide I have for you, and this goes with Gesa's comment on who will produce one day prosthetics. Won't it be O&P? And we call, there's an expression you may know, we call that disruptive technologies. And disruptive technologies do threaten existing technologies. As a Stuttgart boy, I was raised in the town where Mercedes produced the first cars. This town thinks we can produce cars. They always laughed at Tesla. Now they know that they can produce pretty good cars and haven't produced cars for 50 years. And that is disruptive. There may be attacks in production by someone who never did that before, and it may be to a quality which is pretty good. So that means our dynamic world has more and more surprises. The risky thing that happens, if you're a well-established company, and I have also some O&P examples here, if you have a continuous innovation process as a manufacturer, not as a clinic, you tend today to overshoot your customer needs. We call that overshooting the market. That means you do that for a long time, but in the meantime you do silly things. You add on features to your cars that no one really uses. And then there is a client who said, I don't need that. There's a cheap car out there which doesn't have that. I don't need it. And immediately you change where you buy. This is what happens to the taxis and Uber. Why should I order a taxi? There's Uber. And that happens in a minute. And no one knew this taxi guy before. And the same is with text message and WhatsApp. People change within a minute. So make sure, and I think that was the good message you said in the discussion round of the last session, do everything that the O&P components and change stays in the room, that you drive that, because it will be driven. Yeah. So therefore, be aware that on the one side there's this continuous improvement that people try to do. I don't want to mention names and manufacturers today, but you may know this one high-end prosthetic hand manufacturer with a very complex hand, and how a not so much known until then smaller manufacturer with a very good service concept, yeah, just really killed a product. And it's not long ago. And this can happen. There's also a prosthetic knee example for that. And so what does the client really need? The minimal viable product is something where, as Gesa said, there may be some young engineers gathering with some young prosthetists who may show up with a surprising product, and then we have to accept it. So keep it in the room. I think that's the most important thing. And take them into the room so that they don't do something that will catch us by surprise. Innovation needs people. Be aware how good medical devices is in innovation. Since 2009, the European Patent Office, which is the head office of all European patent institutions, we have one for whole Europe, documents that every year most new patent applications are in medical devices. Before 2009 it was electronics, but now it's medical devices. This is where most things happen. And we know from our largest interest groups of medical device manufacturers that a little bit over 50% of all new successful innovations are end user inventions. And you as prosthetists and orthotists are end users in that chain. You're not Ottobock, you're the end user, put that onto the patient. And this is, and you know, many of you know products that were invented by one of you, or at least by an orthotist or prosthetist, and became successful. So be proud and aware of your role, and statistics show you're on the right side to drive new developments. This is a German slide, you don't want to see that. I just make now the summary on top. What I did here is with the German faculty in innovation at the University of Aachen, we looked from the success factors in business innovation. We did a study with German prosthetists and orthotists, what seemed to be success factors relevant to innovate out of all these boring things in the background. The one thing is there something like an innovation culture inside a company? Yeah? In your clinic, if a young guy shows up and says, hey, I have this new idea of an ankle, will you tell him, hey, we are putting these ankles on the people, but we buy the ankles. We don't do that here. Or will you listen to him And will the management be open to people bringing in ideas? That seems to be a good prognostic factor. And how close are you with your customers, in that case with your patients, on listening to demands and requirements? And then there is an interesting point, which is always in innovation, a time of what we would call a technological uncertainty. Will there be 3D printing? Will there be others? Will there be more composite? Will there be less composite? These are times with chances. If everything's clear for the next 20 years, it's boring and no change will happen. But this is now a time, you may call it a crisis, but you could call it a challenging time with good chances for new steps in technology. Innovation needs people. We had this today, especially with this funny chair from Tampa. Yeah, the patient satisfaction and the role of the patient. I would think there were times where the patient was like in the way. I know some products where some manufacturers would tell me, hey, this is not made for people. That's maybe the extreme case. That's maybe the black sheep case. But the patient was mainly not always the driver in the past. And I'm proud that I arranged the session at the 2013 AOPA session to bring the American Amputee Coalition with the German guys into this manufacturer-oriented and prosthetics orthotics conference to speak about their needs. And the result of that was, as they say, that afterwards they founded this International Confederation of Amputee Associations, IC2A, after that meeting. So in the meantime, there is a pretty big international group of amputees that can give feedback to you, and you can listen to them and may specify that. Some of them may be funny, others may be relevant and never looked at. But I think now the amputees are a little bit more self-confident, and maybe they are now more interesting to define product specifications than in the past. And then this is also off the track of O&P. How can Apple do such things so dynamically? It's not Apple. They know you can only do that in dynamic networks. Of course, there are kind of contracts in between people, and there's money going back and forth, but use the network of you all in the room and the people you know to make dynamic changes and not try to reinvent back in your office. It seems like a situation that California shows to everyone on us on the planet. In that case, there are always some high-tech institutions. Georgia Tech is one of those. That is always important for that. And then you just meet with partners and partner on something that seems to be the model of the future instead of changing a company over 10 years. This is what I did as a consequence out of one of these lakes meetings. One of you may know we had organized by Tetrick, DOD. I was one of the invited people to the future strategy of rehab in discussion with VA and DOD. Here are some innovation topics and homeworks that I see. If someone wants to do a study on something, we have to search for the most affordable way to make it doable on the clinical side. In Germany, if a company enters a hospital and they ask, may I do a bracing study? The boss would say, yeah, that is 300,000 euros. What he wants to say is, yes, you pay me a PhD position for 3 years. He will never come back into that hospital anymore. So we have to be super flexible for industry to offer the most affordable, doable, serious studies. And I think this is not to be done in the O&P clinic, but this is the responsibility of academic institutions and research hospitals to be flexible on their side as well. Of course, someone has to finance that. Research guys like us, like Georgia Tech, have to create results in applied research that can be easily taken because they're well documented, and the specification meet what the other party needs, so that the research guys are not smiled at but are taken with respect that someone bridges the gap and takes over the technology. Approval bodies, you discussed the L codes and the standards, which is a good thing today. Approval bodies should become more and more quantitative in their needs to have these devices tested that are new. And I think it's not on the shoulders of the O&P clinic, but it's industry that has to do the homework with the products to bring the evidence. You are in some situations today where the manufacturers didn't do the homework, and now you have to try to do the homework with the insurance negotiation. I think that's wrong. That is a German aspect to mention here. It is our action plan for personalized medicine. The German government says the more specific, the better for the patient. The more specific a treatment, the more sustainable and cost efficient for the state. And the more specific, there is chances for new opportunities and devices and markets for the companies as well. So this is why we think a more and more specific treatment does make sense for everyone and should prevent from under and overspending. And then there is an idea, when you look into personalized products, we had this with this wonderful example from Toronto and Uganda. Consider the supply chain. Are you the one who fits on the patient and who designs and engineers, have it printed somewhere else, bring it back, or do the whole thing at home? However, you have to understand the system from the physician to the patient as a supply chain. This is why we work in Stuttgart on this. I think what still misses, and I'm fully confirmed here with GESA, how we measure the human, how we quantify tissue elasticities, localize them, quantify pains, quantify geometries, viscosities, and all that. We need that torque movement, but we don't have them today. Here is more gut feeling in that area. When we have that, then the manual process or a digital process can be fed. The printing machine is good, but the data that go into it are maybe still questionable. So this is an example which we did 2 years ago. Same day, patient-specific design of a prosthetic foot and fitting after printing in night, 6 hours. We had developed a so-called parametric CAD design. This is computer design of a individual torque and effective foot length prosthesis. We measure ankle torque and effective foot length based on rollover shape in the gait lab in the morning. We feed these data into the design without human interface. It takes about a second because it's just a data input to computer update thing. Then we print, in that case, over 5 hours, that low part of that foot, and then have the patient walk in the evening. So it just shows CAD design can help if the data are good, and this is where we still have to do a lot of things if we want to use technology, the input data. And it's already, that's 2 years ago, possible to plan specifically and fit on the same day. You may know one of these examples where it was crazy examples of individual 3D printed full things. And this is an important thing, looking at 3D printing in my eyes, a slide that Dudley Childress always recommended. It's not about high tech, it's not about low tech, it's just about the right tech, however it is. And one aspect about innovation I see is it must be doable. The change from today to tomorrow must be a doable, controllable step. Of course, you need the courage to jump, but the ways from today to tomorrow maybe help with some technologies that are maybe easier to control and small in the investment. One of that may be tools for standardized procedures like these 5 to 10 systems that are out there with different kinds of pressure strategies for individual socket fitting, vacuum, sit cast, compressed air, aqua system, whatever. These things may help to general average quality. They may bring some efficiency into workflow. They may even document some things on the way easily, and that may help. Other doable steps, in my eyes, may be aspects of like just using 3D scanners. You do however you do in a manual process, but the 3D scanner, when used in between manufacture, will show you your rate of change, your history of change, will quantify your output. It may be using a teaching instrument for your young people in your clinic. You see the traps where you always have to change on the patient. So there are other ways beside directly 3D printing, if that step is too large for you to go, where some pieces of technology may help you in quantifying and making some things easier in daily life than today. In my eyes, we need to bring facts to the treatment, more of that. And because of that, we discussed evidence today. We will have this session in addition on Saturday, where all these people will speak about evidence-based O&P and the future there. And then my vision of an evidence-based clinical treatment is that the prosthetist and orthotic really has historic data of the patient. The patient can give feedback about his quantitative difference and quality of life. The manufacturer one day gives all the evidence with the products that go into the workshop. You don't have to discuss them. They give them. And the insurance turns the process of discussing a device into a very fast evidence-based process, like when you order a hip implant into a hospital. It's a 5-minute thing in approval. It's not a discussion with you on the needs of the patient. That's my dream. Positive interpretation of these challenges. Changes may bring highly individualized patient care in the future. Changes may bring evidence to why a treatment path is major in a specific patient for both healthcare cost and quality of life. IT-based treatment chains may facilitate innovations in prosthetic and orthotic devices, may reduce costs. For that, something like a national technology roadmap may be necessary, which may also come out of meetings like today. We decided that for Germany in May, that if we don't make with O&P industry a long-term roadmap, we won't help each other in understanding all this. And the other is O&P in some areas running out of people. And these new gadgets, devices, can also be, beside the sense they make, interesting for young people to go into O&P. And ideally, this all strengthens the future role of the prosthetist and orthotist as the central person in this game. Thank you for your attention. You're always invited to the Stuttgart Beer Fest, which is about to start soon. So this is our panel for the discussion. I took the word innovation as a photo from outside the Innovation Center here in Banff. And we'll now have Yvonne Jeffreys from BCIT, from the Prosthetic Orthotics program here, together with Dr. Silvia Raschke, who's also from BCIT and the Center for Rehab Engineering and Technology, and Gord Ruder, Director of Prosthetic Orthotic Program at George Brown College. So I would think we go directly into the questions that people raise, yeah? Yeah. Yeah. Maybe we start with this one. What are the implications of being caught by surprise by others outside of this field? Silvia, would you like to?
Yeah, I could start with that because I know earlier somebody had asked about what happened with MedLab Sciences and the pharmacists who made that transition successfully. I'll focus in on the pharmacists. What happened with the pharmacists was new software came in, and the sort of their expertise and their professional image that they had around catching drug interactions, understanding what was in the pharmacopoeia guide, and understanding which drugs would interact with which, interpreting the scroll from the medical doctors. All of this changed as things went digital. And at that point, the mistakes that the doctors were making were removed because they had to actually type it in. It would go into the system. The system could catch if the dosage was right, so it was an expert system. And they would also catch the interactions. So at this point, pharmacy looked like it was going to be wiped out by computer software, an expert system. They've reinvented themselves as advice givers and have expanded their scope of practice. So a pharmacist will do things like provide blood pressure measurement and advice on managing your cardiac health, advice on managing your diabetes. They sell a whole range of products. They are now able to give vaccinations as well and be compensated for it. So they found a way of reinventing themselves as this smart system came along that would have actually wiped them out had they not taken some sort of an action. And I think every field right now is open to that. We even talk about lawyers right now with a lot of the software that's out there and services that are available online. Even lawyers are having to reinvent themselves. So this is nothing new. It's something that technology is bringing upon a lot of different fields having to reinvent themselves. If you are not aware of this and don't make a plan, you can be wiped out. Okay, so that's the worst case scenario. There's kind of three scenarios. Either you embrace the change completely and reinvent yourselves, or you're wiped out. That's the other end. What typically happens, though, from someone that I work with that works in this area is that some sort of a hybrid model comes out. And how far you are on that spectrum between fully embracing and being wiped out depends on how engaged you are in pushing yourself in one direction or the other on that spectrum.
Okay, would you want to comment?
Sure. To me, this is an example of disruptive technology, right? So if I were to answer this from my perspective, I've been fortunate enough to have experience in prosthetics orthotics education, clinical practice, and research. And one of the great advantages of that is the number of times I've been brought to opportunities of innovation, and usually interprofessional innovation. And the knee-jerk response is, it's a threat. It's something that's going to take over or take away. It's the enemy. It's a fight we have to use. That's a word I've heard a few times during the day. Or it's just, I'm too busy to learn about this other planet. It's too foreign to me, and it's different. But I think the better way to look at this, and I think it's come out in a lot of the discussions after the panels have finished, is that it's an opportunity. It's a chance to work together. And by combining skill sets, we have a chance to advance. I was speaking with Urs just before he began speaking, and you can be really good at clinical practice, you can have the benefit of education and be involved with research, but no one person, and perhaps not even one profession, can be good at all three of those things. And I think it really underscores the importance of embracing those opportunities for interprofessional opportunities.
Mm-hmm. Yvonne, would you want to mention this about education in O&P and the relevance of at least interprofessional communication?
Yeah, I think Gord sort of talked about that. I think that we, is our glass half empty or half full, and who's in our backyard? And I think working with the other professionals that are out there, and the professional doesn't have to be within medicine, and I think that's sometimes where we have our little blinders on, that we think of interdisciplinary or interprofessionals only within healthcare, and I think there is a huge opportunity to look outside, and we are limited in the number of people that we have in prosthetics and orthotics, and yet there are schools of engineers out there, so of course they're looking at all kinds of gadgets, and they're looking for opportunities to do something different and be innovative. And I think when they ask, or we're caught by surprise, boy, someone's thinking that way, that we should be going, wow, that's great. It's like, let's go with it. And I think we should look at that as an opportunity. And I think by sort of that fear-mongering of not wanting to participate, I think is a disservice to our own profession, in that I think we have to open those blinders a little bit and just look at different opportunities when we have them. And we might actually learn something along the way too.
Yeah, so maybe as a comment to that is question number 2 on how do we marry the need for interdisciplinary interactions with clinical data collection and building evidence-based practices. There's maybe one comment I can say from a German perspective. We are after the US, the medical device manufacturer number 2. And the most critical thing for innovation in medical devices in general that we see is that in future, hospital work and engineering meet in communication in hospital, so that the engineering expertises and healthcare professionals get into communication. They don't have to learn the job of the other. Some of them will be good in between, like you, a little bit like me, because understanding more of the interfaces. But that one aspect to that, we would say, opportunities like you do and enable here, that the prosthetist, the orthotist, the engineer meet in discussion and then shape a future. That is maybe one of the answers. Would you want to comment to this point in addition? Because this is, I think, important now on the, how's that doable, these interdisciplinary interactions, what should we do now?
Maybe I'll start with that. Is that I think the interdisciplinary skill set that comes with the people coming to the table is about communication and teamwork. And we're all bringing different sets of knowledge and different perceptions of things. And I think it's how people actually communicate together that is actually going to be the success of how that interdisciplinary team, but it doesn't matter who's on your team, whether it's the engineers or the physios or the nurses, the orthotists or prosthetists. But it's as they communicate together. And I think one part of that is, the conflict resolution of differences of opinion can be a very positive and powerful part of moving that idea forward. And sometimes that is something we're uncomfortable with, but I think in the end we'll all know that a healthy discussion about different ideas usually brings out a better innovative product or idea.
So now should we go to the question, or would you?
Yeah, I was going to tie 2 questions into that now. So how do we marry interdisciplinary interactions with clinical data collection and building evidence-based practices? And should we be fearful of educating interdisciplinary team members that may fit our patients? The work that I do in both of the sectors that I work in is always done in teams. They're interdisciplinary teams that include clinical practitioners in prosthetics and orthotics, engineers, technologists, industrial designers, and social scientists. And I can tell you right now, not any one team member could do the projects and have the outcomes that we do by themselves. We must work together in teams. And this business of this fear, well, what if one person runs away with the idea and gets rich and the rest of the team gets left behind? We work under quality systems and have a very structured approach to what we do. This feeds into evidence-based practices. So I work under a really tight business model, the way ERS does as well. If we don't make budget, we will get fired. I have to think always first, who's going to pay for something? How are we going to make money on this? And the clients we work with, we also have to think about how are they going to make money? I'm like Kevin O'Leary on the Dragon's Den and Shark Tank, and I'm not joking. I have to be that cruel with our potential clients because it's always about the money. How are you going to make money? Who's going to make money? Who's going to lose money? There's the fear again. Who am I threatening? By using this quality system approach and the team approach, it actually neutralizes a lot of that threat because you're very open and transparent and you lay it out all on the table. So I think that interdisciplinary teamwork and achieving better outcomes, higher outcomes, more profitable outcomes through interdisciplinary work can really be helped by using the structured, neutral approach that some sort of a quality system approach, some sort of a clinical practice model, the clinical practice software can afford you. So that's how, in my team setting, we deal with some of these threats and try to turn them into opportunities for people.
So I would, after this, propose that we go maybe one each to these many questions that are raised now. I would like to start with one. I think that's in the logics. Is there more to be seen? Because that was the next one was that fear that now people. Okay. So will questions go away and then? So here, technology, software innovations are only tools. How can we make that doable? How can we catalyze lasting change in our busy day-to-day workplace to move OP forward? Corey, do you want to say something about that stressy thing?
Yeah. I think what I would want to do is turn this around for a second. People that have been practicing in the field, say for a decade or more, you think of yourself as a P&O clinician or technician. That's how you define yourself. But what I want you to do is go back in time. What were you before you got interested in prosthetics or orthotics? You had skill sets. You had things that you thought were important that would make you potentially into a good healthcare provider as a technician or a clinician. And I think the way I would spin this back to this is recognizing that that's still happening now. Just your perspective is one of, however long you've been in this field. If the people that are getting interested in this field right now, they have skill sets that are completely foreign to those that have been in here for a long time. And I think that's where some of that threat comes from. What's important is recognizing that these skill sets that new people coming in, I'm always going to have an educational bias, I have to admit that, but new people coming into this field, they will be bringing those things as strengths. And if you're talking about examples like Yvonne and Sylvia are giving, it's that you're working in a professional capacity where you still have that opportunity for people to bring things into the room. And things like technology and software innovations are just like the latest fad. I think the fact that our younger professionals are coming in, they come in with the familiarity of that technology and that software. So it becomes a lot less threatening. And if anything, if we can attract some of these people that have, crazy ideas or really entrepreneurial or from an out and left field type thoughts, and they're at all interested in getting involved with this profession, we should do everything in our power to bring them in, because then they become part of our system.
Jason, please.
I was just going to comment on the question that went away first, which was the interdisciplinary / documentation issue, which is quite a complicated issue.
Yeah.
And what I've seen in our area and from the national conversation has been that the prosthetist notes are not recognized as let's say, as part of the reimbursement package, let's just say. But the physician's notes are. And so from a professional perspective, how did we get ourselves in that situation is one issue, and that's another hour-long conversation that we probably don't want to go down. But the reality is that there is some of that back and forth communication that has to happen in the private sector, in our part of the world, of course, between physician and prosthetist, of sharing information, sharing notes, and most importantly, because of where we are from a policy perspective, the physician's notes have to include basically the prosthetist information in them, or vice versa, as part of that reimbursement. The other thing is, in our VA site, and what we're trying to launch nationally is, we're trying to do, as we work more toward managing these veterans with limb trauma that are more in need of orthotic care, is in this interdisciplinary clinic on orthotics that we're trying to launch, we've created notes that actually, if I said require multidisciplinary input into the note, it's probably a little bit too far, but it probably actually does, where there's some information in these new notes that we've developed for these clinics that requires some medical background, so the attending physiatrist has to make some input. There's some physical examination outcome information that the PT has to make some input. And then there's some description of the technology where the orthotist has to make some input. It is time consuming, but it forces the interdisciplinary team when they're in clinic to have a dialogue. And when you actually witness it, it's really, I think, what we kind of envision should be happening in clinic. And I agree with you, Sylvia. I think it breaks down some of that sort of, this is my turf kind of phenomenon that we think about. So I'm not saying that's a reality that can happen in other sectors, but it's something that we're trying to work towards. So.
Thank you, Jason. There is now in the one of the way game that there were two questions just now, like in a way on trust and future. Yeah. So I think the aspect of how do we work effectively with other disciplines that sell themselves to funding agency. So it seems to be there is one aspect of how do we work together, and maybe of how do we work with people we don't trust yet fully. Is that in the sell? Does it inside? What you want to cover on?
Yeah, I guess I wonder when it says, provide the same service, is it really the same service? And that if we can sort of stay to our foundation in prosthetics and orthotics of sort of materials and controlling sort of what we're doing to the body, the physios will not, they won't encroach into, they don't tend to want to encroach into the engineering fangled stuff about prosthetics and orthotics, because they're very much about the physical assessment and that part of the treatment. So I think that maybe it's really, again, with that role clarification, is that what is it that they're doing and what are we doing, and that, using our language to describe what we consider part of prosthetics and orthotics, and understanding the other disciplines' language in what they're describing, and are we actually talking about the same thing? Maybe we're actually enhancing the whole concept by describing it to a funding agency in many different facets, which actually adds more power to the whole argument. That we're not actually talking the same thing.
Thank you. So part of it's knowing what the language of your audience is. So speaking to a minister or deputy minister requires one language. Speaking to the reimburser requires another language. So you have to speak multiple languages. And I think evidence-based practices, the objective measures that come out is one of the things that really gives you the competitive advantage against some of these others. Others are using them. Learn to use your own. Learn how to sell those. It is unfortunately a business that you're in, and you have to understand how to be an effective business person and marketer. One thing that came out of some early research we did, and I think this is really good news, talks to a different question there. How do we innovate collectively to ensure the public knows that we are still relevant? Our focus groups that we did with amputees going into the evidence-based practice chain of projects showed that the amputee by far sees the prosthetist as the expert and the most caring person about their care. Okay, and that is your primary market there, is the actual amputee. Can you engage them to help advocate for you? I don't know. But you still have them, and you absolutely have their confidence.
Okay. I think that's a really important point. The other is, maybe it's evolution. Maybe this piece that we're losing by someone else taking it over, maybe that's meant to be. Maybe the other way of spinning this is, what are other areas that we can get involved with that we're currently not doing? You gave some good examples with the pharmaceutical industry. We can do the same thing. And I think that's where this taking advantage of those opportunities with other innovations is critical.
So there are two topics on that, as you just mentioned. How do we innovate collectively? And then the last one, how is that in the prosthetic orthotic schools? Will there be adding hands-on exposure to digital technology as part of the curriculum? What would you think, Ivan? Will technology go into your curriculum, or what's the best way forward?
I think it's not going away, the technology. So I think the school has needs to produce prosthetic and orthotic graduates that have foundational skills, and I think this is just becoming another foundational skill in being able to communicate with the other people that are involved on whatever that interdisciplinary team is going to be, and that digital technology is going to thread through all of those different disciplines. So I think it's, again, understanding what we're trying to get, where we're trying to go, how we're going to get there, and then also looking at the other people on our team in that innovation and sort of see where can all those ideas fit together, and then we can come up with a better system or a better idea of what to do in the treatment. And so I think the schools are embracing the technology. I think it's not, you know, for sure, we're not only producing people that know CAD/CAM, but it would be remiss not to understand how CAD/CAM fits in and have some exposure to that in the program.
From our perspective, it comes into three different prongs. One would be hardwired into the curriculum, where, and I think, as Yvonne says, you can't have that overshadow what's currently being practiced. Our education has to reflect what's being currently practiced. If we're good, we're just slightly ahead of that wave so that we can have some of that put, as I said, hardwired into the curriculum. I think the other two ways of doing it are making this as research opportunities, right? So we have students that need to complete research projects as part of their curriculum. And that's where we can start to look into how this and other forms of technology may work or fit into our profession. And then the highest level would be sending our students off into other master's or PhD programs that are, you know, specifically focused on addressing P&O needs.
Yeah, I think there too, Canada is so small that we can't solve these problems on our own. Germany is too small and can't solve their problems on their own either. We're actually working internationally, and I think P&O has to have this kind of international collaboration, both at the research level, I'd love to see more at the clinical level, and at the educational level as well, because we just don't have the critical mass to drive the innovation if we try to do it on our own. Even in the US, there's been a split now with Hanger kind of doing their own thing, so I can't speak to that. Maybe Geza or Jason can speak to that. Is there even enough critical mass in the US for you guys to do it all on your own? I think we'll get a lot further, a lot faster if we look beyond our borders and look outside ourselves. So I think that's the most effective way of innovating. The survey that I have was co-developed with Stanford, Georgia Tech, and with the Veterans Administration at the Fraunhofer Institute. So any strategy that comes out of that will be found out to all of the institutions so that we can work together to solve these problems. And we want to hear from you what your gaps are, what your challenges are, but also what you see the opportunities are to expand a little bit, to become more competitive. I think there, in any time of crisis, there's way more opportunities than there are risks. But people get bogged down in the risks and sometimes get stopped by those risks.
Yeah.
I just want to add one more thing. It's kind of interesting. I'm just thinking is that at BCIT we run a lot of clinical shadowing. So you know I work very hard in collecting some of these contacts for the students to go and see different allied health professionals. But it does make me actually ponder the thought is maybe we should actually be knocking on the doors of other technology places and actually having a little bit of placement in technology, and maybe we should actually be thinking, again, take those blinders off and don't just think about what it looks like in our field, but also just a little bit outside of healthcare and bring some of those ideas together, because maybe actually we might have some interesting stories coming back from some of those placements. So it's just something I think about in response to, you know, what people are talking about.
Thank you. So there are now some questions which look like at profession definition and profession aspects in general, like how do we innovate collectively as a profession, and how do we ensure our focus is still on the clinical specialist role, and what's about the next generation for the importance of the definition of the O&P professional. Does someone from the audience or from you here want to comment on these profession politics questions in a way. Tricky. Jason, please.
I mean, I'd love to hear Gates as another educator, and Brian, I mean, definitely as an educator. But in my time as the Academy's president, there were a lot of opportunities to write some different commentaries and editorials about the tenets of professionalism as they relate to P&O. And I'm so glad to see that somebody's put that up here, because we talk about what's our role with technology and, you know, how do we innovate as a profession and all these things. And I think really at the end of the day, if you look at what some of the other professions have done well, they've maintained the tenets of professionalism for themselves and carried that forward. You know, and not to list them all, but think about them for a minute. You know, having a discrete body of knowledge, the college education, the mentored training experience and all that stuff. And what do we get out of that? I mean, we have those things, right? But we continue to do things like describe ourselves as technicians. We're not technicians, we are professionals. And everyone should be using that language that's a member of this profession. We do have a body of knowledge, a number of us in this room contribute to it. And you can clearly see within these scholarly works the role of the professional prosthetist in those pieces. I mean, you can't do these different research projects, which are in many ways emblematic of clinical practice, without the contributions of the professional O&P person participating in those. So, yeah, I think that's very important that we, you know, lift that up and carry that forward. I mean, it's all about the language. It's all about building that body of knowledge and these things. When we start defining ourselves by the technology, I'm a better prosthetist because I fit sea legs. Yeah, that's a dead end. That's gonna run out. There's an end point to that. But when we talk about we're providing care and maintenance of these devices and helping people achieve their goals with these things and reach certain levels of function, you know, now we're talking about something that's sustainable. I would argue that's what we're doing. I hope others feel the same way. But I couldn't agree with whoever put that question up there. I mean, they're definitely hitting the mark in my opinion.
So thank you, Jason. I think you did the final comment as time is over now, and thank you for listening.